So my topic is assisted suicide, shifting paradigms of physician-assisted death. My goals today are to explain current trends that are pushing us in these directions. And I'm going to be looking at both sides of these issues. One important caveat right off the bat, you may wonder why I'm using the expression physician-assisted suicide. It's the older term and it's a little bit more descriptive. There are some newer terms that are less loaded, that have less baggage, such as medical aid in dying or assistance in dying. And those are good terms. I'm going to continue to use physician-assisted suicide because of its descriptive benefit, but I don't intend that in any moral sense. I don't mean that to be pejorative in any way. It's simply descriptive. It helps us in our conversation together. Here's another caveat and a commitment. I'm a man of Christian faith. I don't assume that my audience here today shares that perspective. But my personal stance is that I'm opposed to assisted suicide for reasons that will come out in this presentation. But you know what? I'm an ethicist. I love teaching both sides of questions. And I believe in normative ethics. Normative ethics is ethics that applies to everyone. So I have a two-handed approach. I'm a two-handed bioethicist. And so in this presentation, we're going to look sincerely and passionately at both sides. Honest, we really are. And in this presentation, I'm not going to use religious arguments. I'm going to use non-faith-based arguments that allow all of you to discuss these matters in a pluralistic context, because faith-based arguments are not going to work with everyone. So I'm going to present both sides. Against assisted suicide, which is the traditional view, we'll use arguments based on tradition and professionalism. The arguments in favor will be based on autonomy and a particular understanding of compassion. So let's just start briefly with the legal context. And just this morning, I've had to update these slides because of recent events in the last 2 weeks. So I like the picture along with the statistics which allows you a visual. So currently, since 1994 in Oregon, we have a total of 10 places where assisted suicide is legal. They include Oregon, and by the way, these are in chronological order from earliest past laws to the most recent. Oregon, Washington State, Vermont, California, Colorado, the District of Columbia in 2016 as well, then more recently, Hawaii, New Jersey, and Maine. Now, there was a Supreme Court case, a state Supreme Court case in Montana that said that there was nothing in their state laws that prohibited assisted suicide. And many people interpreted that to mean that assisted suicide is legal in Montana. That's really not strictly true unless you want to be the test case, because there's no governing statute. And all of us, whether we're physicians or pharmacists, we have to act under regulations promulgated by our state professional societies, state professional organizations. So in Ohio, that's State Medical Board. For us, for pharmacists, it's the State Board of Pharmacy. So we have to act under regulations that have the weight of law, and Montana doesn't have that yet. Update, New Mexico has just passed in their General Assembly the Elizabeth Whitefield End-of-Life Options Act, and it is currently on the governor's desk awaiting his signature. And I haven't heard yet how that's going to go. So it looks like there will be a new statute, or possibly, if the governor signs it, in New Mexico. These are typically called death with dignity statutes. And as we'll see in a moment, dignity is kind of a slippery term, and we'll want to dissect that a little bit. So there's a legal landscape. I'm not going to spend a lot of time on this, but there are some requirements that I'll just touch on. You have to be at least 18. You have to be a state resident. You have to have decision-making capacity. and you have to have a terminal illness diagnosis with death expected within 6 months. Physicians need to have a license in the state, and they need to give good informed consent, and next of kin must be notified. There's some timeline requests, and it's worth noting that pharmacists usually dispense the medication. Probably the most common medication is secobarbital, giving in a dose that would, we're kind of relying on a side effect to achieve the effect intended, which would be suppression of the driving mechanism in the pons and medulla for respiration through the phrenic nerve and based on central and peripheral chemoreceptors. So it's also worth noting that not all, but most of these laws have provisions for conscience, so that physicians don't have to participate and pharmacists do not have to dispense these medications if they have a concern about it. Why are we talking about all this now? We could spend our whole hour just dissecting that, but it's the biotech century, folks. We're in this new environment where it seems like all of the latest scientific advances are in medicine. There's a lot of fear of death out there. And I think that's only been prolonged by the pandemic. Autonomy is the kind of ruling the roost in terms of an ethical driving factor. I have a problem with that, which we'll talk about. And the healthcare professionalism and individual professional conscience on the part of clinicians is under increasing scrutiny. Well, let's get to the arguments. I'm going to start with the traditional arguments against it, and then I'm going to try to equally argue for this. And I'm going to try to spend about maybe 8 or 10 minutes on each to allow plenty of time for discussion. And I sure hope you disagree with me or give your own side or whatever, and I'll be really interested in that. Okay, so I said this is the traditional view, and it is. We have a 2,400-year tradition under the Hippocratic Oath that have the direct taking of life is deeply embedded. Prohibitions against that is deeply embedded in our religious and legal codes. And so there is a Jewish oath, the Oath of Maimonides, which is similar, that goes back to about 1000 or 1200 AD. But the way I've sometimes said it is that doctors don't kill their patients. It's the do no harm of the Hippocratic Oath, and so that seems fairly straightforward, but it's not necessarily dispositive. It's not the final argument, as we will see. If you really want to be an ethicist, you have to use Beecham and Childress, which is Principles of Biomedical Ethics, now in its 8th edition, by the way. Medical principlism. So we have beneficence, acting in the best interest of patients; non-maleficence, avoidance of harm; distributive justice, treating everyone the same. More recently, from the 18th century Enlightenment, we have making our own decisions. Autonomy is much more recent and is more something that came under the Enlightenment and subsequent movement of modernism. So if you're an ethics nerd like me, you talk about Immanuel Kant and Kantian ethics. I know you all are very familiar and can recite exactly the 2 categorical imperatives. And if you can't, I understand. Not everybody's an ethics nerd. But, Kant said, only do something if you can make it a rule for everybody. Interesting theory, and it kind of helps to work. It's a non-religious based argument, although Kant himself was a very devout Lutheran. And if you try to make your ethics based on Kant, then medical assistance with dying would violate Kantian ethics, because you can't make it a maxim for everybody. It would create illogic. doctors could always kill their patients, and it would violate the trust idea of, of, uh, of medicine. The problem with Kantian ethics, it can't deal with conflicts because sometimes we have competing duties that are generated by ethical rules. So autonomy comes into conflict with non-maleficence. And so we have to depart from Kant to get a stronger argument to deal with the arguments against assisted death. I think of the relationship that doctors in particular have with their patients as a covenant. That's certainly the way Hippocrates described it in his famous oath. And if you want to use a legal term, it's the fiduciary relationship with medicine. Medicine is a gift of trust. It implies a deep, embedded relationship that is more than a contract. A covenant implies duties on both sides, and we have a duty to remember the covenant with our patients. According to the argument that I'm representing now, assisted suicide erodes the covenant and breaks the trust relationship. And then you're going to hear a lot about slippery slopes in this session. We're going to look at both sides. But the argument goes that it's a dangerous slippery slope because once you start killing, you don't stop. It's dangerous for doctors and other healthcare professionals, dangerous for the country, and dangerous for every patient. And there's reasons for that. You may be at this point familiar with Brittany Maynard, who passed away in 2014. She was a woman with a young person that chose social media to talk about her brain tumor. She traveled to Oregon and put all of her thoughts on social media, and then she took her own life with assisted suicide because she didn't want to face that. Lawyer Wesley Smith has said, if assisted suicide is now considered courageous, which is what all the news media were saying, doesn't that imply that people who don't choose it are somehow undignified and maybe less courageous? A friend of mine, a scholar from who's now the director of the Kennedy Institute of Ethics, quoted Martin Luther King when he said, Martin Luther King's grandmother told him, Martin, don't let anybody ever tell you you're not a somebody. Everybody, black or white, healthy or sick, is a somebody. Assisted suicide has the intention of making a somebody into a nobody. In other words, to make them dead. And that violates dignity. That's a strong claim. And Dr. Solmazy is a friend of mine, but he's using a term that not all of us get. So another ethicist colleague of mine helps us by helping us to see that it depends on how you define dignity. I don't want to take a lot of time on this. I just want to say that some people say that our dignity is based on our functions. Therefore, if you're on a ventilator or if you're in a lot of pain, you don't have the same functions. Therefore, you've lost dignity. Others would say that dignity is built in. From religious perspective, it's given by God. So you can't take that away. We all have dignity, no matter how sick we are. So it depends on how you define dignity as to how you make these arguments. In some of the debates, in one particular source by Finlay and Dr. Solmazy, they felt that this idea really tends to target vulnerable people, people who are minorities with less education, the elderly or the disabled, anyone whose lives are seen as a burden on society, kind of a utilitarian ethic. And then they back it up with some statistics. And boy, I'm not going to spend a lot of time on these. Please read my paper to dig into the stats. But Arthur Kaplan, who's a former ethicist at New York University and somebody that is quoted a lot, presents this interesting stuff from the European experience. If you look in the Netherlands, being tired of living was one of the main reasons that people went for euthanasia. Now, remember a definition here. Nowhere in the United States is euthanasia legal. That's actually doctors killing patients as, kind of mercy killing. What's legal in some places in the United States is assisted suicide, where the patient actually takes the drug that causes death. But I will tell you that in Canada, both assisted suicide and euthanasia are legal throughout Canada. But this is a European experience, and over half the patients were elderly. That bothers this author. In the Netherlands, 1 in 30 people in the Netherlands died by euthanasia in 2012, which was 3 times the number back when all this was legalized back in 2002. One more thing from Belgium, the idea of assistance with death has skyrocketed, with approvals going very, very high, and tiredness of life is being allowed as a reason, and huge numbers among women, elderly, those with lower education, and nursing home residents. Some nursing home residents in both the Netherlands and in Belgium are going to extreme measures. They're tattooing "I want to be resuscitated" on their chest, and all kinds of, you hear these wild stories, but there's fear of involuntary killing in nursing homes in these countries. And so this is where people get the slippery slope language. And this is worrisome for those who oppose it, because it's all about pain, isn't it? Actually, no, it's not. Inadequate pain control is less than 1/4 of all of the requests. For most patients, it's all about loss of control. Almost 90% said they wanted to choose this option because they've lost autonomy. They can't engage in their normal activities. Sounds to me like these are disability issues, and that should give us pause. So once again, Wesley Smith is worried, I won't read the whole quote, that the right to die will morph into a duty to die. Okay, that was quick. But our time is short. So let me go to the other side, and let me be as balanced as I can to show you a few holes in that first set of arguments. Okay, what about that old Hippocratic Oath? Well, that's really a principle-based oath. We call it in ethics deontological. And it doesn't really have much philosophy undergirding it, except for tradition. Strong religious overtones. And, when's the last time we bowed down to Asclepius and Apollo and Hygeia and Panacea and all the gods and goddesses? That's a polytheistic society. And today we're mostly secular. So don't use religious arguments to appeal to this code. And besides, Hippocratic practitioners are very paternalistic and elitist in their opinions. And of course, back in the day, there was no such thing as autonomy. And modern day autonomy is very important in medicine. Patients have the right to make up their own minds about things. And furthermore, there's a strong kind of a pro-life bent in the Hippocratic Oath, because the Hippocratic Oath was against abortion as well. And so that doesn't represent the diversity of opinions today. Many people are pro-choice, and so we ought to acknowledge that. And the modern healthcare environment is so much more complicated because we have all these machines that can prolong life today. Not everybody wants that. So let's talk about dignity for a minute. Well, dignity only works for people that can find meaning in their suffering, and not everybody has some higher purpose in mind or has a religious viewpoint. So furthermore, if you do polls like in Colorado when they passed their assisted suicide law by referendum, there's a huge majority. I think in Colorado, something like 65 or 68%. So across the board, when you do surveys, 70% of Americans want assisted suicide to be available. So as one author put it, you want to respect my dignity, then you ought to respect my choices. Peter Singer, don't you love him? He's the world's best known utilitarian philosopher, still has a special endowed chair at Princeton University. He would put it this way: death is bad. We shouldn't promote it. But assisted suicide should be an exception. For those that are terminally ill, death should become our own autonomous choice. And we would make that choice when we no longer have any value in our continued life. In other words, we have no reason to look forward to more life, would be another way of putting that. And we're not hastening death. We're talking about withdrawing treatments, which is ethical. And it all hinges on intent. Now here, look, folks, I'm going to make this strongest argument here in this slide right now. And I want you to pay real close attention because I think this is one of the best arguments in favor of assisted suicide. So you should know, if you don't already, that the withdrawal of a treatment that is no longer effective is perfectly ethical, okay? People withdraw ventilators, dialysis, and other types of medical support for patients all the time. We also know that it is ethical to sedate a patient until they pass away. It's called palliative sedation. That's ethical too. And then we have this idea of choosing to take a drug to take our own life, which is available in some places. If you think about it from a utilitarian perspective, any one of these three kinds of things has the same end result. What makes the first two legal and arguably ethical, and the last one not so much, has to do with the intent of the doctors and other clinicians. We're not supposed to intend to cause death. We're supposed to allow to die. But that's a very subjective and unmeasurable thing that is largely irrelevant to the patient. So why would we deny a comfortable death to those who don't fit the requirements for the first two? See how that goes? Why would we deny a patient assistance with their death if they don't fit the category of withdrawing a futile treatment or sedating them until they pass away? Think about that. It's a good argument, folks. Our freedom and democracy is all about the right to choose, and governments should not impose their religious values on others. I'm in a hurry so we can get some conversation going. Just one quick word about slippery slopes, and then I'm going to finish. When you quote from Europe, you might be guilty of the conflation fallacy. As a philosopher, I love those terms, okay? Basically, you're comparing apples and oranges. These are small European countries that are much more socially homogeneous than the United States. We are a very pluralistic society with all kinds of values. Look at our political debates and, from the left and the right now. And given that heterogeneity in our society, existing protections are much more vigorous. Now, I don't want to dive into these stats for the sake of time, but if you look at the Oregon data, which the law has been in force since 1997, there's no evidence that palliative care and hospice have decreased because of the availability of assisted suicide. And furthermore, in Washington state, less than 60% of patients who were given these drugs actually used them. In some, it was just the peace of mind of having them available. That was what they really wanted. So once again, you're eroding that slippery slope sort of thing. So let me summarize, and then we'll get to some Q&A. Those who oppose assisted suicide are going to argue from human dignity, from tradition, and the erosion of the doctor-patient relationship, and they're going to talk about slippery slopes and the abuse of minorities. Those who support it talk about, well, society needs to get more comfortable with death. We need to understand autonomy. The majority of Americans are in support of it. Providers can opt out based on their conscience, and there's no evidence of a slippery slope. So we're all going to agree that we need to have better training in palliative care and hospice. But at that point, we're still having a debate. I'm going to stop those slides and open it up. Go ahead, take some shots at me, and let's see if we can have a good discussion here. What questions come to mind?
Just right off the bat, I guess, so this is a little bit less about the arguments and more about the way in which you have them. I feel like one of the things that's difficult talking about topics like this is, like, if I'm discussing with someone that holds the alternate viewpoint, is trying to keep that civil, because, you know, discussions like this can be very personal and like people get very heated about them. So as someone, in your own words, you say you like controversy. How do you sort of make sure that things stay civil and respectable so that like a dialogue is happening as opposed to an argument? Does that make sense?
Oh, Rachel, that's such a great question. Thank you for posing it. You have gotten to the heart of one of my primary values as an ethicist, and that is I want my students to learn to respect the moral integrity of others. We need to honor one another. Why is it in our political debates today, we're hating on people and unfriending them on Facebook because they have a different political view? Oh my goodness. I mean, why can't we talk about religion and politics? Well, it's because we fight. But if we respected one another and actually had the opinion that the other person spent more than 2 minutes thinking about their opinion and actually had a reason for it, I always tell my students, wow, you disagree with me. Tell me why. Did everybody hear that? That was a really good argument. Would somebody like to disagree with her? You know, so that's the way you see how you might do that, Rachel? So I think you can do it, but you're right. You've got to be really careful, and you got to let people know you don't have an agenda. You're trying to dialogue, get the main arguments out there. I don't know, kind of like I tried to do today. I hope I did. I hope I've been respectful to both sides today. And I gave this presentation at the annual meeting of the Bioethics Network of Ohio in Columbus. And people from all stripes were in the audience, mostly physicians, about 300. And I got a huge standing O because I was being respectful to both sides. And I think that's the key. This is not the moment to try to win arguments. This is the moment to try to help people dialogue one with another. And that's how we all learn. So thank you for a good question. Somebody else. What's your opinion on this subject? And give me one reason why.
I'll jump in here just to add, if anyone is uncomfortable asking a question since it's being recorded, feel free to send me a question in the chat and I will ask on your behalf without mentioning your name. Also, I'll go ahead and end the recording about 10 minutes early so that we can have a portion that's unrecorded, just so that everyone's comfortable.
That's a good plan. Thank you, Connor.
Yeah, and thank you, Maria, for suggesting that.
I actually have, I think it's a question. It's very badly worded still at this point. But like, it's a background I'm very interested in care for individuals with intellectual and developmental disabilities. And how does the care for their life, I was really intrigued by how you pointed out that the main reason many people choose physician-assisted suicide is really because of disability in life. How does maybe that overarching like change in attitude, again, that you were kind of talking about how physician-assisted suicide could lead to, maybe hurt or change how we think about and care for individuals with disabilities? I guess just my personal opinion that it could in one sense be again a slippery slope of starting to devalue those people's lives. I thought it was very interesting. I once worked with, again, people who work with individuals with autism for a long time, and they were very, one time said they were against the notion of what it seemed like organ donations, just being very open, not taking into account like the age as much, just like first come, first serve. And they were like, no, it should go to people who like need the most, who are like the least disabled, the most likely to lead a healthy life. And I was very like struck by, these are individuals working with people with disabilities who were like, by their very nature, would probably be at the very end of the line if you were going to make organ donations in that way. And I think that's what something that greatly concerns me in this debate is how this other debate devalues those lives, if that makes sense.
Thank you so much for your concern. I love the way you express that. And we need to be very, very careful about functional views of value. Okay. I've written a lot on personhood and personalism and how it kind of gets at that human dignity piece where dignity on one view is diminished by suffering or by disability, whereas dignity on another view is something we all should have. And so I worry a lot in this day and age that we have views of value and that are you know, as you get older, people want to be less of a burden. So, you know, they're willing to, you know, that goes into their reasoning for wanting assisted suicide because we as a society don't value them. See? And so I would, you know, I'd be more comfortable with someone choosing to end his or her life if I really felt that it was an uncoerced idea, that they weren't basing it on self-hatred, feelings of lack of self-worth, that their lives no longer count. And so, you know, when you see in a day and age, I just saw there was some, just yesterday, there was some documentary movie that was coming out and the director's 98 years old. You know, I was amazed at that. And we see a lot of emphasis on, even in secular society, we see the value of each individual. I think that's a healthy stopgap, but you still see, you know, Ezekiel Emanuel famously, who's related to Rahm Emanuel, who used to be mayor of Chicago, has written an article in a medical journal that said that at the age of 75, we ought to stop getting colonoscopies and any other tests because you've lived your life, you don't have any value after that. Hello. You know, as somebody who's 69, I take umbrage at that. So, you know, I'm very worried about the diminishing of value in our society. And I think that is pushing people into these kinds of choices. And by the way, I'm really worried in Canada because in Canada, we are now talking about paying people for their organs. And they're going to add organ donation for people who are euthanized or who have assisted suicide. How's that for a slippery slope, Lori, for you? So the problem with slippery slope arguments is that if they're not backed up with statistics, it's actually a moral fallacy. And as a logician, I don't want to use fallacious arguments. But if it looks like it could be a slippery slope and you see data to show that in fact it's leading trends, then you can make the argument. You just have to be careful with those arguments. So points well taken. Anyone else?
So yeah, I had a question. Something that I've thought about. I took a class on ethics in undergrad, and we talked a little bit about it. And kind of the place where I get confused, or just kind of makes me think, is that like as physicians, we have a duty to do no harm. But then when people are like in such an intense pain at the end of life, like there seems almost to be more harm of prolonging their life than kind of letting them end their suffering, so to speak.
Yeah, Nathan, here's my biggest quandary. So remember earlier I said that pain and suffering, in people with terminal illness, it's not always just pain. In some cases, it's breathlessness. For someone in end-stage lung failure, for example, who's not going to go on a ventilator, they need to be treated for the symptoms of breathlessness. That's suffering also. But to your point, actual physical pain and suffering is relatively rare. And with advances in palliative care, titrated spinal anesthesia, self-administered morphine drip, all kinds of things that you can do in a hospice environment. True pain at the end of life should be rare. And there's also the ethical option of palliative sedation, which means that I had a good friend who was suffering with pancreatic cancer with unrelenting back pain. And basically, with his permission and that of his family, he chose to be sedated until he passed away. That's not, it sounds a little bit like euthanasia, but I don't think it is. I think it's ethical legal. But to your point, Nathan, there will be, I'm going to be honest, and there's going to be a small number of patients that are going to be suffering, that maybe their pain is longstanding enough that they're not candidates for palliative sedation, and they really want to have this option. And there comes a point when my therapeutic contract, my covenant with the patient, I have a conflict of interest. And I'm going to look them right in the eye and I'm going to say, I can't help you. I can't help every patient. I'm not God. I can't help you. And I won't do that act because of my profession, because it's bad for the professionalism of medicine as a whole. That, I think, I'm really conflicted about that. And that's probably what I would say. Okay. Remember, I'm a former practicing surgeon. I've had dying patients. But I'm going to be very unsettled because, in a way, I feel like I have let them down. I've violated my trust in a way. So I'll tell you that if that narrow case, I'm very unsettled, which makes me a lot more sympathetic to those who favor assisted suicide. Now, to be honest, when there is a death with dignity statute that has been sent to the Ohio General Assembly, and I've testified before both the Senate and the House in Ohio on a number of occasions on various issues. But when that comes before the Ohio General Assembly, I'm already have several organizations that have asked me to testify against it, and I will. So I'm being very honest. I'm opposed to assisted suicide, but I want you to know how much I am sympathetic to the other side and how much I understand and respect the ethical considerations that have gone into those who want to choose that option. Is that helpful, Nathan?
Yeah, I think so. Could you actually dissect the difference between palliative sedation and like euthanasia? Or
Okay, great question. So in euthanasia, as is practiced in Canada, you can actually take a syringe full of a injectable narcotic, such as Dilaudid or hydromorphone or other injectable, and you can inject it in a dose where you're relying on the side effect of respiratory suppression to actually cause cessation of respiratory drive and subsequent death. That is active euthanasia. I don't like the terms active and passive euthanasia, but that's direct euthanasia. It's legal in Canada to do that. There's a number of requirements for that. Palliative sedation is the titrating by a specialist of a palliative care physician or hospice physician or hospice nurse, where you're giving incremental doses of medication to put the patient asleep. So you're giving sedative medication. Propofol with a propofol drip is a good drug that could be used for that purpose, which causes unconsciousness but does not suppress respiratory drive. So it sounds close, but and you say, well, they're gonna dehydrate or they're gonna starve to death if you do that. Actually, at end of life, terminally ill patients have lost their desire for food and have lost their thirst sensation. So they're not taking oral nutrients anyway. And it's typically understood in a hospice environment that giving IV hydration to those patients is inappropriately prolonging their suffering and their end of life. So that in a hospice environment, we don't rely on nutrition and hydration forced on patients because those drives have diminished. So in fact, you see that it's subtle, isn't it, Nathan? It's a hard thing to do. Somebody just posted in the chat. So it's not the sedation that causes death. The death is a natural process. That's one way of putting it, and I think it helps a little bit to say it's a natural process. It's the difference between killing versus allowing to die. So thank you for the chat comment. I liked it. But the argument against all this, Nathan and the person who weighed in on the chat, is that it's Peter Singer's argument. It's our intent as clinicians that's making these calls, not for the patient. It's all just it's a bunch of hand waving and philosophical stuff, and the end result's the same for them. So says Dr. Singer, and I get his argument a little bit there. So I'm trying to be true to my commitments as a professional, but some of that, if I'm really hard on myself, some of that's maybe a little, forgive me, a little bit self-serving. Like, well, I'm the professional, I don't do that sort of thing. Maybe a little bit legalistic, like some people of faith I know. Sorry, but that's not necessarily. Do we then cave in completely and do anything that patients want? I have a really bad cold, Dr. Sullivan, and I've had it for 2 weeks. So I want you to give me antibiotics. Am I going to do that? Of course not. If I want to be a professional. So being a professional has a lot of connotations and rules that make this complicated, right? And if it weren't complicated, then anybody could be a doctor. Anybody could be a member of our professional guild. We are supposed to be self-regulating. We are supposed to internally prevent abuses. And we should be depending on laws to do that for us. We should be governing ourselves as competent, compassionate professionals. So that sometimes my arguments may seem like a bunch of, how many angels can dance on the head of a pin, but the arguments matter. Ethics matters. Learn to become fluently multilingual in ethics. Learn the different ethical rules. Remember that beneficence, non-maleficence, distributive justice, and autonomy, those are not regulations. Those are principles. And as we say in ethics, they're prima facie principles. They're the starting point. But you got to find the balance. Today, we've been talking about the balance between autonomy and non-maleficence. That's the two principles, right? Or we're gonna take life, or we're gonna respect autonomy on the part of our patients. There's my two-handed ethicist routine. So when we use medical principlism, the 4 rules, we've got to find the competing duties that inform them. And that's why ethics takes a lot of practice, and you can't plug in a formula to solve ethics cases. And that's why we have ethics committees. I serve on 2 ethics committees for 2 area hospitals in the Dayton area. So I kind of got off on my ethics professional frame, but I wanted to see that this is a good conversation we're having as a profession. This is very appropriate, and whatever side you're on, I respect you for it. To Rachel's point, let's not get into shouting matches. Let's learn from one another and respect one another. I think that'll get us there. Any other comments? And Connor, if you want to close out the recording now, and we'll see if there are any other comments off of the recording. So thank you all.
All right. Well, I know I speak for everyone here when I thank you, Dr. Sullivan, for your presentation. It was a joy to hear.